We just had a remarkable discussion on minimal residual disease, that is MRD testing, which is certainly one of the hottest topics in myeloma today. Issues such as how to measure it, how deep do we need to go to measure it, does it predict for progression-free and overall survival, can we use it to make clinical decisions? And I have some of my wonderful faculty sitting here who participate in that discussion. I'd like to turn to them to perhaps get some of that discussion going again. So for starters, we have Roger and Bruno and Nina and Joaquin who presented their data and have discussed this. Do we believe that MRD negativity should be our goal with initial treatment of myeloma?
There's certainly compelling evidence now from a range of studies, and these were all presented at the session, about the overwhelming effect of MRD negativity on outcome, and certainly the data with highly sensitive techniques would suggest a very favourable outcome from those that achieve disease levels below 10 to the minus 6. So certainly that should, I think, be our goal of therapy.
Bruno?
Well, I was just sharing with Joaquin while we were in the podium that this is the session in which you see the people become more passionate about a single topic with every discussion there. I think we are just blessed because we have now the techniques, highly sensitive techniques that we have never had before, and the results were good before. So just imagine how the results will be with the newer techniques. We have many different treatments that are highly effective with a good tolerability, which means that you can combine. Plus, we have now some criteria. It may not be perfect, but we have a starting criteria which should allow to unite how we measure MRD all around the world. And I think that these three findings happening more or less at the same time really set the stage for the next 5 years for the community to work together, particularly within clinical trials, and try to assess the most important questions about how to use MRD to optimize patients' management.
So Nina, that really is the question. Are we yet at a point where we can use MRD to make clinical decisions?
I think this was very hotly debated because in some ways it's difficult to see MRD and measure it and yet not use it clinically, except that we always know that MRD predicts for a better outcome when it's negative. I think one of the things that was difficult for us to tease out is, what does MRD positivity mean? Overall, it's less good than negative, but not all MRD people who are positive are the same. And so until we know how to further differentiate those people, it's difficult to make a clinical decision, or difficult to say that we have to make a clinical decision on it. But it's a very touchy subject.
Yeah. Joaquin, is the goal MRD negativity?
For clinical trial and approval of drug, I think so. For clinical decision, we have to learn a lot of other disease like CML.
Like CML, yes.
Yeah.
Back to Roger. Should MRD be part of all clinical studies at this point?
I think we should be doing clinical trials where we're using MRD to answer key clinical decisions. That will allow us to tailor therapy. And as I say, I think we need to be looking prospectively at this so that we will then be able to answer for the community whether a positive intervention based on an MRD assessment, whether that means intensifying therapy in the context of a positive or increasing value, or de-escalating or stopping treatment in the presence of persistent negativity, is something that improves the overall outcome for patients.
Bruno, for those out there who don't know a lot about MRD testing, can you maybe comment on the advantages and disadvantages of, say, flow versus next-gen sequencing?
Well, I would start with I would say the most important requirement, which is to use or to work with a next generation technique, very sensitive one. Providing you are there, then I don't see that much of a difference between one method or the other. You always find discordances, but these will be few, and we need to see what is their clinical implication. But bottom line, to work really with very sensitive methods, because as we have seen, both from the flow world and the molecular world, even MRD levels as low as 10 to the minus 5 or 10 to the minus 6, they are correlated with a short time to relapse. This being said, it's important to know that there isn't a technique that is 100% perfect. Each technique has its own set of advantages and disadvantages. Cost, for example, flow is cheaper, molecular is more expensive. Molecular has the great advantage that you can store sample, centralize sample, and then analyze later on. Flow gives you the advantage that since you need to analyze in 24, 36 hours, you can actually use that fresh sample to analyze the quality of the sample. This is important in order to preclude a false negative result just because it was blood and not MRD, and then do other studies like Nina suggested to try and figure out how to discriminate between an MRD positive patient with a high risk of relapse at the short term. And we know from many other clinical studies that patients with unsustained CR, let's say during the first year, they usually have dismal overall survival, patients that are difficult to salvage, and then other MRD positive patients that can enjoy a very long-term progression-free survival, even off treatment. So I think this is important work to be done in the future.
Harder to standardize flow, though.
Well, or sequencing, it's the same. You have methods, and fortunately in myeloma, we are really, really blessed because we have two great methods. It's plus imaging. Other hematological malignancies are not as advanced as myeloma. So we are really fortunate. So one thing is the availability of methods that have been optimally developed, well validated, and the other is adhesion to those methods. Ultimately, it will be the adhesion to the methods that will dictate how much standardized they will be. Different concepts.
Nina, one of the discussion points was whether early MRD negativity is better than later MRD negativity. Could you comment on that?
Yeah, I actually was very impressed by the data that was shown, kind of looking at this, saying that for patients who were able to achieve MRD negativity before starting maintenance, those patients did better than the patients who achieved it after starting maintenance therapy. And even though that was sort of sub-analysis, I think it was very informative because we know that if I had a patient who did one or the other, I would know that they would behave a little bit differently. Again, not knowing whether we'd make treatment decisions based on this, but just understanding their disease course a little bit better. So probably getting there earlier is a surrogate for how easy it is to treat their disease, and it's something about their disease. We don't know how to get there earlier just yet. Maybe some forthcoming novel combinations.
Joaquin, to hit again on the issue of different kinds of relapse. We're recognizing so many more varieties of myeloma. Could you comment a little bit on that?
Probably, in my opinion, the problem of, for example, of high-risk patients is that they achieve CR, they respond very well, but they are MRD positive. We can identify very well this patient because if the patient that achieve MRD negativity is high risk, have good prognosis, but a few number of patients achieve MRD negativity in the Highrisk group of patients. The other thing is the control, the immune control of the minimal residual disease. Some patients that Bruno showed that last year, some patients in MRD positivity have a immune control of the MRD. And this is very important. It's very important to identify this kind of patient in the future.
I would like to echo on Joaquin because, well, and also now the Buffalo group has also provided some new data on the transplant-eligible setting about immune monitoring, but it's still far ahead from us. What many groups, the Spanish, our UK colleagues, the French group and others have shown that if a patient is high risk cytogenetics at baseline and persists as MRD positive, outcomes are usually very poor. And I think this is clearly an unmet patient population for other clinical trials
we don't have any good
alternatives.
treatment for this patient.
So this is a patient we would like to react to if we see that and do something. We don't know what, but do something different,
We should
not
design
just
a
sit on
clinical.
it. Yeah, for sure. Roger, you have tremendous data in non-transplant eligible patients. It seems that there's no difference there. That is, getting to MRD negativity is important in that setting too. So if you have an 80-year-old patient, is the goal MRD negativity?
Ideally, I guess the answer to that is yes, but we need to balance that against our overall goals of therapy in context of comorbidities and performance status, etc. But our data shows that MRD, our achievement of MRD negativity does provide a survival advantage in that setting. The general principles that we have demonstrated before in terms of its independence of therapy and the value in terms of survival benefit according to log reductions of disease has been recapitulated in that setting. An MRD negative remission is the same regardless of what therapy you've received, and it's also regardless of age. So we have done that analysis. So for elderly patients, it still remains a goal, but clearly that is not necessarily achievable in the context of the whole
in every
patient.
patient, yes. Bruno, as we were walking here, you mentioned your plans or somebody's plans to try to reach out and help standardize flow. Where are we going with that?
Well, during the last 2 years, many laboratories, for example in Spain, have received investigators from all over the world. We have organized also workshops for investigators from country A, B, C. We have also traveled a lot, and I'm really...
You can certainly come to San Francisco. We need the help. Thank you.
And I'm really delighted to say that we have seen amazing implementation and reproducibility of data in a large number of countries all around the world. I can tell you that the latest figures I had was that the method was being done in more than 40 laboratories outside of Spain, spread around 16 countries. Wow. So I think that it's progressively growing. I think that in parallel, we should now work, as we are working in fact, on setting up a quality control system. This has been done, the UK they have an outstanding experience about this. This has been done for other diseases, for example, AML also in the US. So it's possible, it's feasible, and I think it's desirable to make a quality control so that we know that all these laboratories are performing the assay at its peak performance.
Nina, you're a recent convert. Do you believe in MRD now?
I think not only from what I've been taught by you, but also because of today's session, that I really do think MRD is the new CR. And if we use CR, PR, VGPR to tell us how our patients are doing, we also can use MRD as an endpoint in clinical trial in that way. Again, we don't know now more than ever what CR would mean for PFS or anything like that. We think it'll predict. So I think that MRD negativity should be the new standard for which we say, okay, CR, and if you're going to judge a drug being approved on that, I think that is fine.
Thank you very much.